Good afternoon and welcome to today's caregiver webinar, How to Support a Loved One Living with Brain Injury. My name is Allegra Jaffe. I am a social services specialist with the Caregiver and Supportive Service Unit with the Fairfax Area Agency on Aging. Before I introduce today's speaker, I will go over a few housekeeping items. We have enabled closed captioning if you need it. You can enable them on your Zoom panel. Today's presentation is being recorded and a link for the presentation will be sent a week from today. There is a Q&A button where you can submit your questions. And lastly, there will be a brief survey as you sign out. So please take a moment and fill out that survey because it helps us create programs that are relevant and important to our caregiving community. So now it's my pleasure to introduce today's instructor, Dr. Jessica Johns. Dr. Jessica Johns, MD, is an assistant professor in the Vascular and Critical Care Division of Neurology with the VCU Department of Neurology. Dr. Johns joins us most recently from the University of Virginia, where she completed her fellowship in neurocritical care. Dr. Johns completed her residency at Wayne State University Detroit Medical Center, where she had the opportunity to provide care to the urban and underserved population of Detroit. Dr. Johns looks forward to continuing her passion of servicing underrepresented minorities here at VCU to foster an environment that is both inclusive and rewarding for both patients and staff. Dr. Johns has her MD from Wayne State University School of Medicine and a BS in biology from the University of Miami. When she is not working, Dr. Johns enjoys baking, hiking with her dog, collecting bourbon, reading mystery and suspense novels, and crocheting. Dr. Jessica Johns, welcome, and thank you so much for being here today. We are looking forward to your webinar.
Thank you so much for having me. Let me share my screen so you guys can see my slides. Okay, I hope everybody can see my screen. So like Allegra was saying, my name is Jessica Johns, and I'm one of the neuro ICU doctors over at VCU. And so I have no disclosures of conflicts of interest for this presentation. And so some of the objectives that I found for this presentation are, I just kind of learned the basics of the brain anatomy, learn about different types of brain injuries, and go through different levels of recovery from brain injuries and how you guys as caregivers can help a loved one with a brain injury and how we can support our caregivers. Okay. So kind of brain anatomy 101 is basic. The brain is divided into two main hemispheres, the right and the left hemisphere. And one of the fun things about the brain is that everything is crossed. So the left side of the brain controls the right side of the body. The left side of the brain is very important in your ability to speak, to communicate with others, to talk. It's important with writing. While the right side of the brain controls the movement of the left side of the body. And the right side of the brain is very important in insight, emotions, and it's really the more creative and artistic side. And then each hemisphere of the brain is divided into different lobes. And so we can go over the different lobes. The frontal lobe, which is in the front, which is the pink area of this picture that I have here. The frontal lobe is really important in our memories, in being able to make decisions and judgments in our behaviors. And it's really important with our personalities. And when there's an injury to the frontal lobe of the brain, we often see patients that have personality changes. They will become aggressive or agitated. And that is something that we do frequently see in patients, especially with traumatic brain injuries. They will become aggressive to our staff in the hospital, but we know that is part of the injury. The parietal lobe, which is the yellow area in this picture, is important in our sensation, our ability to move our arms and legs, and being able to tell where our arms and legs are in space, which is an important thing that we have, because it's difficult to move if you don't even know where your arm is. And that really depends, especially if it's on the left side of the right side of the brain, that will be a problem. And then moving on to the temporal lobe, which is the green area in this picture. Temporal lobe is really important in our memories and our ability to talk with others and understand what other people are saying to us. Some patients are able to get words out, but it doesn't make any sense because they are not understanding what we're asking them to do. Patients with temporal lobe damage frequently will have seizures. Seizures can come from any damage to the cortex, but it's most frequently seen with damage to the temporal lobe. And with temporal lobe damage, you can also start to see behavioral changes such as aggression. And then we have the occipital lobe, which is this bluish purple in the back here. And that is, the occipital lobe is really important for vision. If there's damage to both occipital lobes on the right and the left, then a patient would be functionally blind. And there's actually a really interesting neurologic syndrome where the patient is blind, but they don't realize that they're blind. And we have seen that, especially if there's damage to both occipital lobes. And then moving on to the back of the brain, we have the cerebellum, which is this gray area here. Okay, and the cerebellum is really important in coordinating movements and making your movements appear smooth. When there's damage to the cerebellum, patients will often walk very unsteady and they have difficulty with balance. They almost appear as if they're drunk, which is alcohol actually affects the cerebellum, which is why patients with cerebellar damage walk that way. And then the brainstem, which is this area here that's not labeled, that's a very important area of the brain because all of the tracts that give us sensation and movement and our ability to breathe and our ability to be conscious and awake, all of these fibers run in a very small area. And it doesn't take much damage to doesn't take much injury to cause a lot of damage. And if there's damage to the brainstem, that's when your patients or your family member can be in a coma or what we call a minimally conscious state. Okay. So what is a brain injury? The simplest definition of a brain injury is any damage to the brain. And it can lead to changes in a person emotionally, mentally, and physically. It's very important to remember, though, that just as no two people are the same, no two brain injuries are the same. Families will often ask, especially in the acute phase of injury, what kind of disability is my loved one going to have? How is my loved one going to recover? And these are very challenging questions because everybody is different. And everybody recovers differently. It takes everybody different amount of time. So we can kind of give general predictions, but we can never be certain about how patients are going to recover. And typically my answer is always, we just have to take one day at a time. And so there are two main types of injury. I think when most people hear the term brain injury, they think of a traumatic brain injury, and that is a brain injury secondary to any form of trauma, whether it be a car accident, a fall, just a fall from standing up or a fall from a ladder, any sports related injuries. These are your concussions or patients that get injured in sports, bike accidents. And then you have your acquired or non-traumatic brain injuries. So these are things that happen, that injuries to the brain that are not due to trauma. So the most common brain injury that's not due to trauma that we see is a stroke. And whether that's a hemorrhagic stroke or an ischemic stroke, but there's also, you can have lack of oxygen to the brain, which can cause a lot of damage, any form of brain infection, a meningitis, and brain tumors. They also can cause a lot of damage to the brain. So I'm mostly going to be talking about traumatic brain injuries, but a lot of the things that I'm going to mention can be related and extrapolated to non-traumatic brain injuries, the acquired brain injuries. So traumatic brain injuries can be classified as either mild, moderate, or severe, and we classify the injury based on how long if the patient loses consciousness and how long that unconsciousness lasts. And obviously, the longer somebody is unconscious after an injury, the more severe the injury is. And again, every brain injury is different. No two patients are the same. Even two patients with very similar brain CAT scans are very different patients. Okay, and patients can present with a variety of symptoms. And severity can range from very mild headaches, and then we'll see those in patients with mild brain injuries, and those are your typical concussions that you see from sports. And then you have the severe brain injuries, the patients that are unconscious, and those are frequently bad car accidents. Okay, and patients can have balance issues, difficulty speaking, decreased attention span, personality changes, difficulty moving one side of their body, or if their brain injury is on both hemispheres, then they might have difficulty moving all of their extremities. And these symptoms can be from an initial injury, or as the brain injury progresses, we have what is called a secondary injury. And that can lead to new symptoms that can develop after the initial injury. So with traumatic brain injuries, we have two main scales that we use to look at the severity of the injury. The first one is the Glasgow Coma Scale, and the second one is the Rancho Los Amigos Scale. Okay, so first we have the Glasgow Coma Scale, and this was developed in 1974 by Dr. Teasdale and Dr. Janae at the University of Glasgow. And it's the most frequently used scale, and it's probably one of the easier ones to do. And this gives us a very good snapshot of how a patient looks. And we use it when a patient first arrives, and it evaluates a patient's response to how their eyes are moving, how they respond with any verbal response. Are they talking? Are they just moaning? Are they not doing anything? And how are they moving their arms and legs? Are they following commands? Are they just moving it to painful stimuli? And this scale allows providers to quickly be able to describe a patient to other providers. So if I hear a patient has a GCS of a certain number, I know what that patient's probably going to look like. And this scale, as I have it over here, runs from 3 to 15. All of us have a GCS of 15. We're awake, we're talking, we're moving. And so 15 is the best, and the worst you can get is a score of 3. And so then we have the Rancho Los Amigos scale, which was developed in 1973 by Dr. Hagen over in California at the Rancho Los Amigos Rehab Institute. And this scale is used to look at the cognitive and behavioral patterns seen in brain injury patients. And it looks at the consciousness of a patient, how awake they are, and how much assistance they need from others to do their daily tasks. And this scale has 10 different levels, and it can be used throughout the recovery process. And this scale is really nice because it allows caregivers and others to see that what the different scales might be and how their loved one may progress through recovery. And so I have made slides with all of the different levels of recovery. We're going to briefly go over them, but I think that you guys have access to these slides, so you guys can go and look through in more depth afterwards. But also I do have resources at the end of good resources that have a good scale too. So your level 1 patient is your lowest functioning patient. This is a patient that is in a coma. They don't respond to external stimuli. They need 24-hour care in doing all aspects of life. And as a patient progresses through these 10 levels of the Ranchos Los Amigos scale, their amount of assistance that they need will decrease and their independence will increase. So moving on, I want to point out at a level 4, these patients are agitated. This is part of the injury. And agitation and aggression is often very distressing to family members. I have countless experiences of patients with traumatic brain injuries, and families are very distressed that their loved one is swearing at staff and fighting us. And I will always bring out this scale and say, this is expected. This is kind of part of the recovery process. We don't take any offense to this. We know that it's part of the brain injury. And families are often like, he's a good person. And I was like, I know he is, but he just has a brain injury, and that is part of this. When patients get to level 6, they are starting to interact more. They're starting to follow commands. If you ask them to give a thumbs up, they'll start to be able to do that. And they start to relearn familiar tasks, such as brushing your teeth or combing your hair, things that you do every day. And when you get to a level 7, the amount of assistance that your loved one is needing is starting to decrease, but they still need to be supervised. At levels 8 and 9, the memories start to improve. You're requiring less assistance from your caregivers. You're doing more things independently. And this is the point where depression in your brain injury survivor is starting to set in. They're realizing that they can't do the things that they used to be able to do. They're realizing that their life is forever changed, and they start to struggle with that. And they're realizing that the impact that this injury is going to have on their life. And we'll talk about the different stages of grief and processing later on. And so when we get to level 10, patients are almost back to where they were. It's unlikely that they're going to be the exact same person that they were, but they're being independent and they're able to function, and they potentially could go back to a job. And it depends what kind of job they held before. They may not be able to go to that job, but they may be able to hold a job down. And it's important to realize that not all patients go through all the 10 levels, and it's possible that, especially in a very severe brain injury, that they may not even make it to level 10. They may stop at a level 3 or a 4. And it's also important to realize that there is no time frame for progressing through these levels. Your loved one may stay at a certain level for a few weeks, months, and they may plateau at that level, or they may continue to get better. Again, there's not a great way of saying how patients are going to recover. Okay, so how do we treat brain injuries? So kind of the initial treatment when a patient has a brain injury, whether it be a car accident, a fall, we initially stabilize their physical condition. Frequently, patients with severe injuries often have medical complications for other hospital stay, especially if they've been in the ICU for an extended period of time. They can develop pneumonia, other infections, blood clots, difficulty weaning from the ventilator, difficulty swallowing, and those things can delay the recovery process. But we try to minimize the risk of secondary injury and complications to the best of our abilities. And all brain injury patients, whether it be a traumatic brain injury or an acquired brain injury, will be evaluated by physical therapy, occupational, and speech therapy. And the therapists are very pivotal in determining what type of therapy your loved ones need when they leave the hospital. And so once patients leave the hospital, there's kind of a variety of settings where patients can go. If a post-hospital treatment will vary depending on the severity of the brain injury and how the patients are recovering. So patients with a very mild brain injury may be able to go home with outpatient therapy, whereas somebody with a more severe brain injury will require intensive therapy at a dedicated brain injury rehab center, which there's a few around. And at rehab, patients will relearn basic skills, brushing their teeth, combing their hair, relearning to walk, and working on strength and balance. And rehabs have multidisciplinary programs with physical therapy, occupational therapy, and speech therapy so that your loved one can regain as much independence and strength as possible. And then prior to discharge from a rehab, teaching will be done to the caregivers so that you can provide the best support for your loved one. And so obviously, as a caregiver, having somebody you love have a traumatic brain injury it definitely impacts your life as well as theirs. And it is normal to grieve and feel overwhelmed after a loved one has had a brain injury, especially if it's a severe brain injury and the patient is in the ICU. Having someone you love in the ICU is very overwhelming, and seeing all of the medical devices and tubes and beeping and loud noises can be very scary. And it's also common to feel very helpless at the beginning because there's not much you can do. Your loved one's life is in the medical staff's hands. And everyone processes and copes with this change very differently. And I mostly take care of patients in the ICU in the initial phase of brain injury. And I see the whole gamut of responses from loved ones when somebody is in the hospital. I'll have some family members that cannot leave the bedside because they're afraid something is going to happen if they leave. And then I also have loved ones who can't come to the bedside because they're very overwhelmed and they don't want to see their loved one in that condition. So we see everything, and there is no right way to cope. Everybody is different, but with time you will adjust to this new normal. And like I said, this is a grieving process, and there are 5 different stages of grief that you can pass through, and it might be a linear, you go through each step individually. It can be all over the board. You go from one step to another, you go back and forth, but these are the things that typically people will go through. It's normal to grieve. And like I said earlier, not only do caregivers go through this grief, but your loved one, the person who has sustained a brain injury will also go through these different stages. So the first stage of grief is denial. So this will after the initial shock of the injury has worn off, reality is kind of starting to set in. This is when we start to move into denial that the injury occurred and that the diagnosis is wrong. I often take care of stroke patients as well, and I will patients will say, I didn't have a stroke. I don't have any weakness, I'm fine. When they can't move half of their body, they're just in complete denial of it, and they will progress through, but it's part of the grieving process. And you often try to cling to this false reality that everything is okay. The second stage of grief is anger. And this is when you start asking, why me? Why us? Why does my husband have a brain injury? What did we do to deserve this? And people who are at this stage of grieving will often start to lash out at others. Again, in the ICU, we see people that get into the anger phase of grieving. They'll start lashing out at the nurses and the staff because they're angry about that situation that they're in. They're angry that their life has very much changed. And we know not to take it personally, and that this is all part of the process. So the next stage that we see, the third stage of the grieving process, is bargaining. And this is when people will start to say things like, I will never argue with him anymore if he just gets better. Or parents will say, I won't ground him anymore if he can get better, talking about their loved one. And there's often some sort of guilt that starts to come in a little bit too, especially if you were potentially arguing with your loved one before they got into their accident or whatever, and say things like, if he only hadn't been in the car, or if he hadn't been late for work, he wouldn't have gotten in that accident. You're just you want life to go back to the way it was. The fourth stage of the grieving process is depression. So now this is a temporary depression, and this is a very appropriate response to the situation. This is not a mental illness depression. This depression does not need to be treated. And again, it is a temporary thing. This is when you're starting to move into the present and realizing that things are different. You're depressed about how your life is completely changed and the hurdles that you have to get over to get your life back together. And I want to emphasize that this is appropriate to be depressed, and you will get through it. And then the fifth and final stage of the grieving process is acceptance. This is the accepting of the new normal. It's going to be okay. We're going to get through this. You're starting to embrace the different life after brain injury, moving forward to your new way of life. Most people will start to become proactive in helping their loved ones move towards recovery and do whatever they can to help their loved one get better. And like I said before, there is no set time frame in going through the grieving process. Some people go through all 5 stages in a linear pattern. Some people go through 3 different stages. Others jump back and forth between stages. Some people get to the acceptance stage, and then their loved one has some sort of setback in rehab or whatever, and then they move back to a different stage of denial or bargaining, depression. But then as things get better, they move back into the acceptance. This is not a one-size-fits-all pathway, and there's no specific way to grieve, and every person is very different. So what can you do as a caregiver to help yourself and help your loved one who has a brain injury? And I think this is always a challenging one for me, but it's to ask for help. This is the time to rely on your friends, family, support system to help get you through this. So typically when somebody has an initial brain injury, when you're in the hospital, there is a chaplain that is a great point person to help you process. At VCU, we have a chaplain in-house 24 hours a day. If you're religious or spiritual, the chaplain can help pray with you, pray for your loved one. But if you're not religious at all, I still encourage families to have the chaplain come by, because they are a great listening ear and they can help get you through this very challenging situation. They're great to talk to. It doesn't always have to be a prayer or religious thing. This is not the time to be a hero and be a strong, independent person. This is the time to ask for help. If there's ever a time to lean on your support system, it's now. And you will often find that there are a ton of support groups out there for people that have been through similar situations or are still currently going through situations. And being able to talk to somebody who is going through something similar to you is often very helpful. And so the road to brain injury recovery can be very long, and oftentimes there are setbacks through the process. Again, every patient has their own road to recovery, and the recovery process often starts before somebody is discharged from the hospital. And this is where you really have to start thinking about, how are you going to take care of your loved one when they are discharged from rehab? Do you have the medical equipment at home? Does your loved one need 24-hour care? If so, how are you going to accomplish that? Frequently, you may have to rely on friends and family if they just need somebody to sit with them. Maybe you have friends that can rearrange their work schedule so that you guys can take shifts. Or are there, if they just need somebody to be with them and not do a lot of things, is there somebody who is retired who can spend some time with your loved one who has a brain injury? Some insurance companies will help to pay for a caregiver support, but you really have to take that initiative to find that out. And the social workers and case managers know all of these loopholes and details, and they're the greatest people to work with, and they'll be able to help you figure out what you need and what you have access to. So the financial aspect of having somebody with a brain injury is often very daunting. There's medical bills to pay. Your loved one's not going to be able to work for a long time. They may never be able to go back to work. That's a huge burden, especially if they are the primary income in the household. You need to take time off of work to care for your loved one, and that puts potentially your income at risk as well. One of the things I always recommend is that families bring in FMLA paperwork if they have insurance, so that we can get them time off from their job and some payment as well, so that they can spend time with their loved one who's in the hospital still. And of interesting note, I will say one of the good things that came out of COVID is remote working is now more acceptable. Recently, we've had quite a few caregivers that have been able to stay at bedside with their loved one because they had a job that allowed them to remote work, and they were sitting at bedside in the hospital doing their work, which was a huge stress relief for them because they still had an income coming in, and they were also being kept busy and kind of kept active. So there's also government and local agencies that can help with some financial assistance as well. Social Security can have some payments because you can get extra payments based off disability. The VA has wonderful benefits for loved ones that are veterans, especially if they have service connection, life insurance or disability insurance. These are things that you have to purchase prior to an injury, but if you do have those things, they will come in very handy in this situation. There's also frequently local agencies that can help with cost of prescriptions or some sort of fundraiser if you need that, and helping with those funds. In this day of social media, I've actually frequently seen a lot of GoFundMe accounts set up, and I've seen a lot of communities come together and support somebody who has an injury. So, like I've said, recovery after the initial injury takes time. For some, it's weeks to months. For others, it might take years. And that is a lot for a caregiver, as well as the patient themselves, the person who has sustained the injury. But many people with brain injury will go on to lead fulfilling lives. Okay. As a caregiver, you have to stay motivated. You have to continue to encourage your loved one. You have to keep working towards recovery. And like I said before, just as the caregiver goes through those stages of grief, your loved one can go through those stages as well, especially as they're progressing into the higher levels of the Rancho Los Amigos scale, that level 7, 8, 9, 10. They're starting to realize that they have deficits, and that their life has changed. So part of your job as the caregiver is to continue to support them, and help them get through. And as you're helping others, you also have to help yourself. This is a really big, important thing. As a caregiver, you have to take care of yourself first. And that is very difficult to do. And I will always say you cannot care for others until you care for yourself. And I see this in the ICU frequently. I often have to tell loved ones, it is okay to leave the bedside to take care of yourself. Even if it's just to go take a shower, to have a hot meal, you need to take care of yourself, and work on and de-stress, and you have to get good sleep, which is far easier said than done, to get a good night's rest. But if you're not taking care of yourself, that definitely leads to you potentially being more at an increased risk of getting sick, and having your own health issues. And then if you have your own health issues, you definitely can't help care for somebody else. So things you can do to help is to take turns at bedside. If you need to step out to take a good night's rest, take a shower, have another friend or family member who is able to sit at bedside, so that way you have that reassurance that somebody is there, and that if something were to happen, you would get a phone call right away. Obviously, the medical staff will call you immediately, but that friend or family member will also be on your phone telling you what's going on. Exercise, always helpful to decrease your stress. And then finding a hobby, especially something that you could even do at bedside. I personally love to crochet. I actually was able to get a family member to learn to crochet at bedside a couple of months ago. She taught herself via YouTube, and her stress level significantly decreased. And she was over there crocheting blankets for everybody, that she learned to do while she was sitting at the bedside of her son, who had a bad brain injury. And that was something that really helped her. And so some words of advice that I have for caregivers, especially of caregivers for people that have brain injuries, is this is tough, but you will cope and you will adjust to this new way of life. And never give up hope. I know that there are going to be setbacks. For every one step forward, especially in the beginning, there's 5 steps back. But your medical staff will never give up hope. And as long as you will get through this. You have to encourage and support your loved one while still taking care of yourself. And caring for somebody with a brain injury is not easy, but you can do it. And especially from support of your family and friends. This is not an easy task. This is a lifelong task frequently, but with the right resources and the right support, you can do anything. And so I have put on here, and like I said, I think you guys have access to these slides, some really great resources that I have found regarding brain injury, and especially the Curing Coma campaign. There are great resources that are directed for caregivers. And the Shepherd Center, which is in Atlanta, is a big brain injury and spinal cord injury rehab. And they have a wonderful pamphlet and videos on kind of brain injury 101 and kind of the different steps that patients go through. And again, great resources for caregivers. And then there's the Brain Injury Association of Virginia, and then Brain Injury Services. Again, great resources for caregivers and family members. And I know that there are support groups within the state of Virginia, and I know within Northern Virginia as well. Okay. And these were just some of my resources that I use. I finished a little bit early, but that definitely does give us some time to answer questions.
Great. Thank you so much, Dr. Johns. I really appreciate all this great information. I'm going to open up the Q&A to the audience. So at this time, you can submit any questions that you may have in the chat box. Dr. Johns, a question did come in. Can brain injury turn into dementia? Can it eventually become dementia?
So patients with brain injuries have an increased risk of developing dementia. You can get memory problems and memory issues from the injury itself, but especially repeated brain injuries can lead to a dementia-like picture. There's been a lot of stories coming out about football players with repeated concussions having a dementia-like picture.
Okay. Someone, a caregiver who has a loved one who had a stroke asked, when is it time to assess whether dementia is becoming an issue? There's a few things she wrote. Is it necessary to put him through testing process and further undermine his confidence because he's already upset about it? How do I pivot from being focused on therapy for stroke related issues to memory care issues?
Oh, so testing for dementia is not always necessary, especially if we think it's going to upset your loved one to go through that process. If you think it's going to undermine his confidence and everything that's been going on. I mean, the key with dementia is to make sure that your loved one is safe. If they're leaving the stove on or something, then we need to kind of redirect, and maybe they shouldn't be cooking or needing to cook with supervision. Make sure somebody is at home while that's going on. And what was the other question?
Yes. There's a few questions
Sorry.
within it. How do they pivot from being focused on the therapy for stroke related issues to the memory care issues?
So I think depending on if you have if you're inpatient therapy or outpatient therapy, having good physical therapy and good strength, even with dementia, is very beneficial, because having that strength and being able to stand and do those things is important. And you can do both at the same time. Physical therapy with memory help as well.
Okay. So just doing them together, not necessarily pivoting away from one or the other.
Yeah.
Thank you. Another question that came in is, what is your opinion of hyperbaric oxygen treatment for brain injuries? If I said that right.
Yeah. That is not something that I have personally done or worked with. So I don't actually know the research on it, because I have never done it. I've never worked in a facility that has a hyperbaric chamber. So I really don't have an opinion right now.
No problem. Another question came in. Does a client with a brain injury with aggressive behaviors that keeps leaving facilities need to be in a locked facility?
If they're aggressive, that's always a challenging question. The aggression that we see with brain injuries is often one of the most, like I said, one of the most distressing things that families have to go through, because that's not your loved one. Do they have to be in a locked facility? It really depends on the patient. If they are getting out and they are potentially dangerous to themselves or may hurt others with their aggression, then that is something that could be considered. But it really just needs to be on a person by person basis.
Okay. During the grief stage, when depression is present for a while, when do you think we should consider getting a therapist or a counselor?
So I am always a big proponent of a therapist in general, somebody just to talk to and vent to that is kind of a third party is always great. I kind of view our chaplains in our hospital as almost pseudo therapists. That's why I pointed that out. Even if you're not a religious person, just having somebody to talk to is always great. So therapists are always great. Typically, we say if we're approaching like the 2 to 3 month mark and you're markedly depressed, you're not eating, you're not being able to function, take care of yourself, that is when you should consider seeing a psychiatrist to talk about, do we need to start some sort of medication for depression? But if it's a few weeks, going through it for a little bit, like I said, completely normal. It's part of the process.
Okay, thank you. So who does determine if a client needs to be in a locked facility? Is it the doctor that does that, or at the hospital?
So we don't have locked facilities in the hospital per se. Like we have like the psychiatric unit for patients with psychiatric issues, but that is not the patients that we are seeing. These are brain injury patients. So we don't have locked units. We will, if patients are agitated, not staying in bed, we'll try medications initially to kind of try to help calm them down a little bit. But we will, even if we have like sitters outside the room to just kind of reorient people, say, hey, get back in bed. It's okay. You're in the hospital. Frequently, depending on the level of injury, that might be enough. When patients are leaving and if they're in rehab, and then they may need a locked facility, that would be up to the rehab physicians.
Okay, that makes sense. In general, do you see a lot of patients with TBI that need to be in lockdown facilities, or do most patients are able to eventually cope to live at home?
Yeah, so the patients that I see frequently that are agitated will get through that agitation, move on to a different level of recovery in that Rancho Los Amigos scale. But frequently what we need to do in the acute phase is start medications to help calm them down. And as they continue to recover from their brain injury, they will be able to come off of those medications. Again, that is not everybody. Are there patients that will continue to be agitated for a very long time and may require like a lockdown facility or 24-hour very close observation? Yes.
This question's somewhat related. You mentioned that every injury is different, but is there any statistics on how many people with brain injury will fully recover? Are these
I'm not sure of the statistics, but it really depends on the level of injury. If it's something very mild, like a concussion from a football hit, most of those people will go back to being completely normal and they won't even remember that they had a concussion, or you'll be like, oh yeah, I had a concussion 7 years ago and my life is completely normal. If they have repeated concussions, that's a different story. So it really depends on the severity of the injury.
Someone asked a question. My loved one is having trouble driving now after the TBI, and they're concerned about them continuing to drive. Should they talk to the doctor or the DMV, or where should they go when they think they should no longer be driving?
So you can go to both. The DMV does have specific paperwork, to the best of my knowledge, regarding taking someone's license away if you needed to. But you can also, what I have seen is to go to the doctor to kind of make the doctor the bad guy, and that it's the doctor is telling you can't drive, not you're telling your loved one you can't drive. So I think sometimes that works a little bit better if you end up kind of putting the blame on the doctor.
Yeah, that makes sense. Yeah, there's another question that it sounds like you kind of answered it. Someone who asked, how do you talk to somebody about that, about taking their keys away? Um,
Yeah, honestly, it's always challenging when it's someone you love to say, hey, I don't think we can take I don't think you should be driving anymore. So I truly, I've had that conversation multiple times as a physician to family members. And then, like I said, they get mad at me, and then their loved one is like, you can't drive because the doctor said so. I had nothing to do with it. So
yeah,
I think that helps everybody in the long run if you just make the doctor the bad guy.
yeah, so it's not you.
Yeah. So that way you're continuing your relationship with your loved one and continue moving forward.
No, that's great. And so at this time, I think actually we're going to get a few minutes back to our day. So we're going to wrap up our time together. And Dr. Jessica, thank you so much again for presenting for us. We really
Thank you for having me.
Oh, thank you. And I want to thank our audience too for being here today, and for carving out some time. I wanted to remind you that there is the survey. You're welcome to share any comments with Dr. Jessica Johns on that survey, and also share with us what you would like to see in the future. I also want to invite you to attend our next caregiver panel, which is creating support systems for family caregivers. This will be on Friday, August 25th from 2 to 3 p.m. And in this panel conversation, we will explore the importance of creating and finding systems of support that will help caregivers in their journey and learn about different resources that are available to them. So I hope you can join us then. A lot of folks are thanking you for your time and thank you for the great information in the Q&A box. So thank you again, everyone. And I hope everybody has a great afternoon. Thank you.
Thank you.
Take care. Bye-bye.
Bye.